We can start recording, Ms. Kabalina. We can start recording.
Okay, sir.
Recording in progress.
Yes, please proceed.
Good evening, everybody. Welcome to today's session of ISG Kerala Chapter PG Clinics. You all know this PG Clinics are done now with the help of Clarinet, and they are managing the platform, and it's being recorded by them. Today, faculty is Professor Rajesh Gopalakrishna. He is a professor of gastroenterology at Amartya Institute of Medical Sciences. Professor Rajesh has taken classes for you earlier, so he is well known to you. He has lots of publications in the field of pancreatitis. Okay, and the case will be presented by Dr. Saran, Senior Resident, Medical Trust Hospital, Cochin, and the case will be discussed by Dr. Naveen Chand and Dr. Dheeraj. And the moderators are myself and Jayanti ma'am. Jayanti ma'am may log in at any moment. Now over to Professor Rajesh Gopalakrishna. And you may also add some tips during today's class regarding examination, because each examiner will have different expectations of the students. So we would love to hear from you some tips for the candidates when they appear for the examination. Over to Professor Rajesh.
Yes, sir. Thank you, sir. Thank you, sir, for inviting me for this. Yes, I think we can start the case, sir, since it's so maybe Dr. Saran can start the case presentation.
Yes, sir.
Madam also joined.
Jayanti ma'am is already there.
Welcome, madam.
Listening. Welcome, ma'am. Welcome to today's session.
Yeah, please start.
Good evening to one and all. I'll be presenting a case of a 15-year-old boy from Cherthala, Kerala. He is studying in 10th standard. The informant is self and his mother, and the history is reliable. Chief complaints, he presented to our hospital on the 29th of June this year with complaints of recurrent episodes of abdominal pain since the last 3 years, with acute worsening since 1 week. He was doing well about 3 years ago when he developed the abdominal pain. It was an upper abdominal pain. He predominantly localized it to the epigastric region. It was incidence in onset. It was dull aching in character. It was of mild intensity, and it was an intermittent pain, which was more towards the evening, around 3 to 4 hours after the food intake. But this was inconsistent. It was not always after the food intake. It was non-radiating, and the episodes of pain lasted only for around 15 to 20 minutes, and it was self-limiting, and there was no specific aggravating or relieving factors. He had around 3 to 4 bouts of such episodes of pain every year over the last 3 years, of which one episode of pain, which was 3 years ago, was of moderate intensity in comparison to the previous episodes of pain. It was lasting for around 1 to 2 hours, which required a visit to a nearby hospital, and he was given IV injections and symptomatic treatment, and an abdominal scan was also done, which was told to be normal, and the symptoms were told to be secondary to dyspepsia. He also gives history of abdominal bloating and postprandial abdominal fullness, and these were also intermittent, not consistent, and it was not always associated with the episodes of pain. Currently, he presented to our hospital on the 29th of June this year with abdominal pain of 7 days duration. This time also it was intermittent. It was postprandial, 1 to 3 hours after the food intake. It was predominantly in the epigastric region. Now, with respect to intensity, it was moderate to severe in comparison to the previous episodes of pain, and it was not completely relieved by the analgesics which are given to him at home, and it was also again non-radiating. Along with this, he also had 2 episodes of vomiting, which was non-bilious, non-projectile, not associated with hematemesis. He did give history of a low-grade fever prior to the onset of pain for around 2 days. It was not associated with any chills or rigors. It subsided with oral paracetamol. For these symptoms, he was initially taken to a nearby hospital around for 2 to 3 episodes, or 2 to 3 times, and was given symptomatic treatment for the pain and vomiting. But in view of the recurrent episodes and persisting pain, he was brought to our hospital on the 29th for further management. Following admission at our hospital, he was initially kept NPO. He was given IV fluids, analgesics, and other medications, and RT was inserted. And after 3 days of hospitalization, the pain and symptoms improved, and he was started on an oral liquid diet on the 5th day, and by the 6th day, the RT was removed once he was tolerating oral soft diet. There was no history of hematemesis, distension, abdominal distension, constipation or obstipation, awareness of an abdominal lump or jaundice. There is no history of regular drug intake, skin rash, polyarthralgia, or any preceding abdominal trauma prior to the onset of abdominal pain. He gives no history of weight loss, diarrhea, passage of oily or greasy stools, difficult to flush stools. There is no history of diminished vision, easy bruisability, easy fatigability, bony pains, or oral ulcers. His past history, he did give history of dengue fever 3 years ago. He was hospitalized for 2 days and discharged. It was more or less uneventful. He had a recent right lower limb fracture a year ago after a fall from stairs. It was conservatively managed with the below knee cast for a month. His birth and developmental history, as per the mother, it was a normal full-term delivery. There was normal milestones appropriate for age. He has normal scholastic performance at school. He's born of a non-consanguineous marriage. He has an elder sibling. There was history of pancreatitis in the maternal grandfather. He expired at 65 years of age. He had occasional ethanol intake and was a diabetic. Further details were not known as the bystander was not with the grandfather at the time of the episode. There is no history of recurrent abdominal pain in the family members, or there is no history of early onset diabetes in any of the other family members. His personal history, his diet is non-vegetarian. His calorie intake per day is 1,800 kilocalories. He's deficient by around 900 kilocalories. His protein intake is 38 grams per day. He's deficient by around 8 grams per day. Sleep is adequate. Family belongs to the upper middle class as per modified Kuppuswamy scale. So to summarize, it's a history of a 15-year-old adolescent boy with intermittent episodes of abdominal pain since the last 3 years, with the current episode being of severe intensity, requiring hospitalization with relief of symptoms after being kept NP after initial bowel rest and RT insertion. And he with no other comorbid conditions, and there is history of pancreatitis in a second degree relative. So I would like to consider chronic abdominal pain syndrome, probably a pancreatic pain or a biliary colic. And history-wise, there was no symptoms of any malnutrition or exocrine or endocrine insufficiency.
Can you go back to the first slides?
Yes, sir.
So that we can start discussing from the complaint. Okay. Professor Rajesh. So
what do you think is the cause for the abdominal pain in this case? You think it is pancreatic type of pain? Or why you think it's a pancreatic type of pain? If you think so.
Sir, it is not consistent with the pancreatitis phase, but given the location, the dull aching character, predominantly postprandial, there's an exacerbation that he says, which is not always there. And the current episode following admission, he was kept NPO, the bowel rest was given, an RT is inserted. It could be of a pancreatic origin, sir.
no, that should not be the criteria. You have to discuss the characteristics of the pain and then come to a diagnosis, because any analgesic given, any intervention given can modify any type of pain, no?
Yes, sir.
Okay, therefore, you have from the description of the abdominal pain which you have mentioned, you have to come to the correct diagnosis. The past pain, probably we will forget because it was 3-4 years ago. But the current one, I think at least we can discuss and try to arrive at the current problem. Can you show the next slide? Okay, this is the one which you have to discuss in detail and tell us what do you think about it.
So from what I understand, history which you mentioned, nausea,
Yes,
vomiting mentioned in this present episode. But in the previous episodes, you have not mentioned any association of nausea or vomiting. It's only pain only, no?
Yeah, only pain, sir. There was no nausea, vomiting, sir.
So this time the episode may not be the same as previous episode. No, there are some new features.
Yes, sir.
It's more severe. So there are other additional symptoms.
Yes, sir.
So when you discuss, it's better to keep all the options and when you discuss.
Okay, sir.
Sir, yes.
Sir, with this episode of pain, it was a epigastric pain, severe intensity with a postprandial exacerbation. Would like to give probable pancreatic origin pain, sir.
Can this be gastric pain? What is there to negate a gastric pain? Postprandial upper abdominal pain occurring 1 to 3 hours after food intake and then actually settles down, sometimes requiring analgesics. This okay. He had two types. One, he had a pain which was there for many 2-3 bouts in the last 2-3 years,
Yes, sir.
and now the current pain. Do you
Yes,
think
sir.
both are similar or stereotypical, or is the current pain different? Apart from the intensity which you have shown us 8 out of 10, and earlier
sir.
it was lesser. Apart from the intensity, are the characteristics different? That is what we are interested to know.
Apart from the intensity, it is more or less the same pain, sir. Other than the vomiting which was there this time.
No, but what about
Only 2
during?
episodes of vomiting, non-bilious, during the current episode, no? Only 2.
Yes, sir.
Its relationship with the food intake is not mentioned, that vomiting. And what was apart from non-bilious, what was the content? It is food taken just prior or many hours earlier, partially digested, stale, all those things would be any vomiting. When you describe, you have to describe that the relationship with the meals,
Okay, sir.
the nature of the vomiters, and whether any symptoms of the patient is relieved after vomiting. This much we would like to know.
Okay, sir.
It was in your slide
Is
only.
it relevant? Is it relevant to know such details about the vomiting?
No, I think so, sir. He has mentioned that he was given treatment for the pain and vomiting. No? So these were the predominant symptoms in the present episode.
And I also thought that because vomiting was not mentioned initially, so the current problem seems to be abdominal pain and vomiting. No? The last paragraph, you say in view of the severe pain and vomiting, he was brought to the hospital. We are not finding fault with you. We are trying to help you to discuss it in detail.
Yes, sir.
You can continue.
Okay. If
And
you think
any moment we can call in the other discussions also.
so if
Like
you
Naveen
think
and Dheeraj also, they can also offer their opinion
Yes,
and
sir.
whether they want any more history.
I think the abdominal pain discussion was a little monotonous, no? I think, and something saying that it increases in the evening, and that 2 episodes of vomiting, they're all soft signs. They're all very soft signs. I think history has to be more crisp. It will be more like a short case. This particular case that you're presenting will be, don't keep on repeating again and again this abdominal pain. Then again, it lasts for 3 hours. One time it lasts for 7 days. You have to really concise the whole history for the recurrent abdominal pain and say so many episodes per month, or so many episodes in a year, or so many episodes in a week, and how he was in between episodes of pain. I think that is most important. So that you get an idea. And was any intervention done? Did you receive any treatment in between? What was did you have any other problem? I think you're focusing too much on the pancreas, but just think of all the other possibilities, okay?
Yeah.
Okay, ma'am.
Also, was he on any modified diet during this 3-year period? Was he taking what? I think are you coming to all that? Or the history is over. The treatment, anything else in the treatment, or like diet he was taking?
For the previous episodes of sir, he had only around 3 to 4 episodes per year, and in between he was symptom free. He had no other
on
symptoms.
a normal diet, not unrestricted diet.
He was on an unrestricted diet, sir.
Okay, so that is also you should mention. No, that means.
Soren, you said the 3-4 bouts of pain per year over the last 3 years. Okay.
Yes, sir.
And we were that we should know whether the pain was just for a few seconds, for a few minutes, or days together, all those things.
So those 3-4 bouts of pain, it lasted only for around 15 to 20 minutes, sir. But one episode 3 years ago required a visit to hospital. And after that, the current episode is
to hospital, and he remained in the hospital, or just went to the hospital for injection?
Just went to the hospital for injection, sir.
And then when did the pain disappear after the injection?
Yes, sir. By
after
evening,
that, he
it
was
disappeared.
perfectly all right?
Yes, sir.
Because a patient with pancreatitis with severe pain, when you give the injection, the pain may come down, but it will not continue, it will not disappear completely. That's
Yes,
the issue with the pancreatic sort of pain.
Yeah.
Okay.
From the previous episode, it's not typically say pancreatic pain because very short and
Yes, sir.
no documented pancreatitis. So it's clearly
So-
it may or may not be. We cannot say. Suppose you think it is pancreatitis, from the present history, any triggering factors, etiology, can you say from the history which you have given, possible any factors for pancreatitis in a young patient?
Sir, there was a family history in the maternal
that-
grandfather. That's a
History,
second degree.
but anything from the history of the patient itself, you mentioned 2 points, no? Do you think they were related to pancreatitis?
It was postprandial, epigastric, and
No,
this
that is
episode was
I'm seeing some symptoms, something which happened in the history you mentioned, no? In the past history. Can they be triggering factors for pancreatitis?
in the past history, sir.
Think next slide you go. Yeah, in this past history. So there's history of viral fever, no? So is it one of the factors for acute pancreatitis?
Was it confirmed dengue fever or some sort of viral illness?
It was confirmed dengue, sir.
Okay. Is a viral fever relevant in this case?
Sir,
Are viruses known to produce acute pancreatitis?
mumps, Coxsackie, hepatitis A, B,
Yeah,
C.
many viruses which presenting as febrile illness are known to produce acute pancreatitis.
Yes,
Okay.
sir.
One more thing, the history of trauma is there, no? So is trauma a common cause in childhood pancreatitis?
Yes, sir.
So what is the usual which causes pancreatitis, acute pancreatitis in children? Usual types of trauma.
Could be a blunt trauma, direct blunt trauma, sir.
To the abdomen, yeah. So what are the usual settings, most common settings? What type of injury? So one is a football injury, other is
Okay,
a
sir.
bicycle handlebar injury. These are the two common types of trauma. Here is a history of fall from stairs. So it is not clear whether it's abdominal trauma. What you mentioned is right limb fracture. Okay.
Yes, sir.
Okay. So shall we proceed, sir, with the history?
Okay, let him sum up then.
There's past history of dengue fever. All these, I don't know. I think there's too much of a stretch on the history. Candidates
Yeah.
are trying to tear apart the history, which is, doctor, the person who's presenting, what is the relationship of dengue fever 3 years ago? Do you remember what you had 3 years ago? If I just ask you. 3 years ago was, say, 2019. We don't even know what happened then. Now, dengue fever, what is that got relation here? And then you mentioned about that 2 days fever, but subsided with paracetamol. The most important thing is, the way I would go about is, I would just say had several episodes of abdominal pain for that meeting. And then say a typical pain was characterized by, that's all. And just describe one typical pain and then mention what happened in between episodes of pain and whether there was any associated symptoms or was there any complication or requiring an ICU admission or admission to the hospital with any episodes of pain. That is all that you have to describe. And after that, if you think it is still pancreatic type of pain, then you mention about the complication. Just highlight the important no histories related to the complication. This is how whenever there are several episodes, what we do is we say several episodes and describe one particular episode and then say that all the other episodes were similar to this. If there's a change in one of the episodes, then you highlight that episode. Maybe that required hospitalization, that required intervention, that required ERCP or whatever it is. I think that's the way. I think we should give them otherwise the history becomes monotonous and the examiners will not proceed. They'll not proceed. Then that pain for 2 days, then something for fever for 2 days, then dengue fever 3 years ago. It's actually not relevant at all, no? And this fall a year back from the fall from the stairs. What is that got relation to the present clinical presentation? You think it's related? This fall, you think it's related?
The fall need not be related unless there was a direct blunt abdominal trauma.
So just
Yeah,
leave
I
it
think
alone.
that's
Leave
very
it
important.
alone.
There's no abdominal trauma, no? You can't mention there's no abdominal trauma. That's it.
Got a fracture of the lower limb. How is it got related to this particular presentation? I think please don't tear apart the history to such an extent that you take every aspect of the patient's lifestyle day to day. You know, I think that's where the problem started. Okay, continue.
Okay, let him summarize and we'll ask the opinion of others. Can you rephrase your summary? Soren, are you there?
Yes, sir. Sir,
Okay.
15-year-old adolescent boy with prior history of intermittent episodes of non-specific abdominal pain over the last 3 years, with around 3 to 4 bouts per year, with current episode being of severe intensity, requiring hospitalization, with relief of symptoms after a bowel rest and RT insertion, no other comorbid conditions, and history of pancreatitis in a second degree relative.
Yeah, but I think as Sir mentioned earlier, no, you could definitely keep the gastric causes also, no, in this case, no, with the symptoms. So apart pancreatic biliary, and you should discuss further points in favor for each, no, of the.
Oh, sir.
Apart from his family history of pancreatitis in a grandfather or great grandfather, is there any other risk factors for either acute or chronic pancreatitis in him?
No, sir.
What are the usual risk factors you ask for?
In any patient, sir, whether there is a history of ethanol intake, history of, sir, in any
History of
case,
ethanol. Okay.
Yes, sir. History of ethanol, history of
Okay, being
smoking.
15-year-old, we presume that he has.
No, sir, not in this
habits.
case, not in him, sir.
Okay, so in general, what are the risk factors you assess? One is ethanol intake, agreed.
History of smoking.
Okay, not a primary risk factor, but a secondary risk factor. Okay.
And then any history of early onset diabetes or history of worsening of diabetic status.
History of early onset diabetes, that is agreed. History of worsening of diabetes, in which situation you get in pancreatic disease?
So when there's a complication like a
underlying cancer, new onset of diabetes or exacerbation of a pre-existing controlled diabetes which become uncontrolled. Okay, so
any drug intake.
Okay, so regarding first you think of acute pancreatitis risk factor, whether there's any alcohol, it can be there for chronic pancreatitis also. Drugs, agreed. Drugs, trauma we have already discussed. Then biliary disease.
Yes, sir.
Any symptoms suggest biliary. Your pain, the pain of this patient was not very typical. No, most of the time pain lasted for 1 to 2 hours and then disappeared.
Yes, sir.
Pancreatic pain usually lasts for many hours together. That's the one problem. So biliary disease, like a gallstone disease. Okay. Then history manipulation of the biliary tree. Which are the drugs which are responsible for acute pancreatitis?
Sir, drugs, sir, could be diuretics like furosemide, azathioprine, antiretroviral therapy, L-asparaginase.
Okay, so you must be able to say this, rattle of this various list, which and then we said about some viral infections which we mentioned already. So risk factor, what are the risk factors of chronic pancreatitis? When you stress in your summary.
Family history, sir.
Okay, that means hereditary, which is not very common here, but hereditary is a risk factor. Now I am asking a theory question. Then in the family also, there is a slight increased preponderance of chronic pancreatitis.
Yes, tropical pancreatitis, there is a familial clustering.
Yeah, that is it. Then alcohol is basically chronic pancreatitis, no?
Yes, sir.
Okay. In the history, there was somebody has mentioned whether there's any steatorrhea. So if somebody has repeated episodes of pain suggestive of pancreatitis, one should also mention there is no history suggestive of diabetes, no history of any steatorrhea. Okay.
Okay, sir.
So what history will ask for steatorrhea in pancreatitis?
Sir, passage of foul-smelling stools, oily, greasy, difficult to flush stools.
Okay, yeah, that is a good answer because many of the students, they give the classic description of steatorrhea like frothy, foul smelling, all those things. But in chronic pancreatitis, remember that it is quite mild digestion and therefore it is greasy stools, passing of oil droplets and all those things rather than very loose and frothy stools. That type of the classic steatorrhea which you find in either tropical screw and celiac disease is found when there's a small intestinal disease. Here that is malabsorption. After the digestion, it is not absorbed. So all these froth and other things come due to carbohydrate fermentation. But
Okay, sir.
here it is undigested fat. So basically it is a greasy stools or feeling of greasiness of the anal area when they try to clean up, or sometimes they find oil droplets dropping from the anus into the closet and all those things. Okay. So that is the type of steatorrhea you expect in a chronic pancreatitis. So this actually fits in with acute pancreatitis, chronic pancreatitis, or recurrent acute.
So this could be a chronic pancreatitis or with an acute or chronic pancreatitis, or since there is a change in the intensity and character of pain, it could herald the possibility of a complication.
We mentioned 2 or 3 reasons for recurrent pancreatitis. We forgot one important one. Many metabolic condition.
Hypertriglyceridemia, hypercalcemia.
Yeah, hypertriglyceridemia, hypercalcemia. In fact, last week I could pick up a parathyroid tumor in a patient with recurrent acute pancreatitis. So actually, during the third attack, we found it out. It was missed during the first 2 attacks. What could be the reason for missing it, even after sending the calcium?
During the episode of pancreatitis, there could be a fall in the calcium levels, sir.
Yeah, that is it. And ideally, we should have checked it once the patient has recovered, which it was not done. And this time, however, we checked it afterwards and found out that the calcium was in the range of 14 and parathyroid hormone was high. And the scan also showed the classic findings of parathyroid adenoma. Okay. Okay, Professor Rajesh, can we proceed now?
Yeah. One more. What are the common causes of pancreatitis in adolescents and children? Can you mention?
Adolescents and children, it could be a tropical pancreatitis or hereditary pancreatitis. Then annular developmental anomalies like annular pancreas.
Yeah, congenital anomalies can be assessed.
Yes.
Also, in drugs in children, no common drugs actually is anti-epileptic medications and
Yes, sir.
azathioprine IBD medications.
Yes.
Okay, I think we can go.
Can we ask the opinion of other 2 discussants? Dr. Naveen, what do you think?
Yes, sir. Because the pain is not characteristically describing the pancreatic type of pain. I think it's more like a biliary colic, past history of biliary colic. Now maybe the patient presented with an pain which is not relieving for analgesics. It could be an biliary pancreatitis, sir, or it could be an cholestasis as of now, because the patient also had fever, abdominal pain with vomiting in this presentation, not improving with analgesics also, sir.
Yeah, because I was also thinking why there was fever for 2 days. Okay, the explanation for fever was not forthcoming.
One
Okay,
important message: a biliary colic, maximum the patient will have just 1 or 2 episodes. It will not last more than 2. By the time the diagnosis will be made and patient will undergo surgery, that is the severity of pain of biliary. So in a recurrent abdominal pain of 3 to 5 years, biliary colic will never ever come as a differential, because the pain is so intense. First pain, second pain, max. And by the third time, the patient will have undergone surgery. So the so-called biliary colic will never come as a differential in this particular case. Yes, if it was within 6 months, he had 3 episodes, yes. But if it was 3 years and a pain, and one thing I want to point out in your summary, you've written 15-year adults with intermittent episodes of abdominal pain. Where? Where is the site? What abdominal pain are we talking about? Look at that summary, adolescent intermittent episodes of abdominal pain. What pain is it? Is it porphyria? Is it lead poisoning? Is it something else? You have to highlight, what was the site? What was the typical characteristic all that has to come out there. Then when you just give a summary like this, intermittent episodes of abdominal pain, I was just wondering what we were discussing. And the biliary colic will not come as a DD, but other differentials will come in, like, porphyria, then your hypertriglyceridemia, lead poison. All these are the other causes of abdominal pain where the symptoms will be very intense, but there'll be nothing on the finding. I request
Especially
others also,
pediatric
the
practice,
faculty, I
especially
would like the
pediatric practice.
faculty to comment on this, because one is the summary. Summary is not giving any information. Supposing this was your last case, and they ask you to summarize, then you will land up with problem, because when you summarize and you describe this pain, they will say, doctor, what pain are we talking about? Supposing this is your last case or the second last case, that's how it happens in the exam. They will just say, summarize your case and tell us what is your differential. So when you summarize, supposing I was not attentive to your history taking and I suddenly come to a summary, I should be able to understand what is this patient suffering from. When you say intermittent episode of abdominal pain, especially as BT mentioned, it may be just a recurrent abdominal pain of childhood. No, he's just having some problem and he's not trying to go to school. And he has a recurrent pain the way that you've described. Are you understanding?
Yes,
yeah,
ma'am.
very important. These are the types of case. First case will be a long case with detail. But second, third, and fourth, the fourth will be what's your diagnosis and differential. The penultimate case will be give you a summary. The second case, if you've not done well in the first case, second case, they'll again have some flexibility. So please remember, if you were to summarize, supposing I was not listening at all to your presentation and I just came in for for your summary, I should be able to get a complete information on what you're trying to convey. You understand? And suddenly when you say abdominal pains and suddenly you say there's one second degree relative with pancreatitis, on what was the history based on on what basis was the second relative degree diagnosis based, pancreatitis?
Those details weren't available, ma'am. The bystander was not
How
aware.
do you say? Maybe it is a family history of abdominal pain. How do we say that? On what basis do you say that the and that too you've said second degree relative? Now, who's the second degree relative? This is a joint family, is it?
His maternal grandfather.
Maternal grandfather. Children today don't even are there with the parents and grandfather. This is a maternal grandfather. So how do you know that grandfather having a pain due to pancreatitis, how does it relate to your particular case here? How did you make a diagnosis of pancreatitis in the second degree relative? Actually, I was inattentive during your history taking. That's why I got in at the summary. Be very careful, doctor. This is not, please don't take otherwise. But this is the way the exam will go on. Now you're all heading towards exam. Another 4 weeks or 6 weeks, exams will be there. And these are the small things that we're trying to tune you up to. So don't take anything otherwise. We're just trying to tune you up so that your presentation is crisp, it is direct, and it is focused. It has to be very, very focused.
Yes, ma'am.
That's why I said to rephrase your summary. Actually, you are rereading it. Rephrase means the description of you said episodes of abdominal pain in the last 3 years. Current episode being severe. The characteristic of the pain, the duration, the associated symptoms.
Site of pain first.
Yeah, all those things must be relevant. Sure. As ma'am said, in a person with a long history of stereotypical pain, the examiner will drift in their thoughts during a presentation and suddenly catch you during a summary. This is what usually happens. Unless your presentation is having a lot of points. So every episode have same. Actually, it is very likely that they will drift in their thoughts and will come back and ask all the details when the summary is presented, as ma'am has rightly told now. Now, Naveen,
Sir.
Do you have any differential diagnosis? You said about biliary colic, which ma'am said it is impossible because by the time 2-3 episodes are there, patient would have had a scan and somebody would have diagnosed it properly. Still, is it possible to have biliary disease?
Biliary pancreatitis, sir, now. The presentation now. Because the patient also improved with MPO.
I am
and
still asking you, a biliary colic may be difficult, but still person can have pancreatitis due to sluts. Microliths may be there, which may not be picked up on ordinary ultrasound, and it may go on and we may miss it for a while. Okay.
Yes, sir. Rather than larger stones, the smaller stones are more prone to.
Pardon?
Rather than the larger stones, small stones are only more prone to develop pancreatitis, sir. So sludge.
Okay. Is
also
there any other pancreatic disease which can produce recurrent abdominal pain? One is we said idiopathic acute pancreatitis, then biliary. Okay. Biliary, any other apart from the gallstones or microlis, any other cause?
Sir, in this, because 15 years
Pancreaticobiliary
old,
malunion.
pancreaticobiliary malunion, sir. A developmental anomaly, pancreaticobiliary
Okay.
malunion.
Developmental malunion. Okay. Is pancreas division a cause of recurrent pancreatitis?
Sir, unless the patient has some genetic predisposition, they are not prone to develop pancreatitis, sir. Because
Is it a cause of chronic pancreatitis?
no, sir, unlikely, sir.
Okay, now there was an entity called biliary ascariasis, which was very common in children, but now due to good hygiene and all, it's not that easily seen, but you could still get some cases. This was described from Kashmir, and I had seen a couple of cases long back, maybe in 90s, late 90s, I have seen such cases. After that, I haven't seen much. Biliary ascariasis producing pain and sometimes pancreatitis. Professor Rajesh, are you seeing such cases now?
No, we are not seeing ascariasis, but
Not at all, no. Nowadays,
The
we don't
other-
get good.
The other one is Carolis with hepatolithiasis. So they'll keep dropping stones. Those are the patients. Then they'll have ascending cholangitis. So those patients will have more of a cholangitis-like picture.
Yeah, it will be more of a biliary disease with superadded pancreatitis at all sometimes. Okay.
I do not know whether I missed on the history. During this entire period of illness, was no investigation done at all, and no doctor could make a diagnosis in this patient?
Prior to coming, no, ma'am.
No
No, really?
ultrasound, nothing.
5 years, huh? 5 years or 8 years?
Prior to coming, during when he had one episode of this moderate intensity pain, a scan was done, was told to be normal. This time also, he did come with a scan that was also told to be normal.
So what I'm asking you is, so therefore your differentials have to widen, no?
Yes, ma'am.
Your differentials have to widen. Some person would have at least picked up some amylase, some amylase, something on ultrasound, something on X-ray abdomen, something to say that it is pancreatitis. I cannot believe that an MBBS doctor would at least ask for an ultrasound. So what was the investigations done during this entire period of illness? Nothing, huh? No investigations, and you were suffering with pain. Is it not possible, no?
I think ultrasound was done and it was reportedly normal.
Yes, sir.
So all the more you have to be careful in your diagnosis of pancreatitis.
Dr. Dheeraj, is it possible to have a patient with pancreatitis and ultrasound normal? Yeah, ultrasound is a very insensitive technique to detect mild to moderate pancreatitis. Severe pancreatitis, it may, but again, if there is a lot of gas and distension, one may not pick up pancreatitis properly on an ultrasound. So mild to moderate may be missed completely, and severe ones, there are a lot of problems. So
My first differential in this patient will be a recurrent abdominal pain of childhood, adolescent.
Yes.
It is a functional disorder, and I put it as gut-brain disorder interaction as my
This
first
will be
differential.
something, yeah, as you rightly said, recurrent abdominal pain in an adolescent, and that is which had to be investigated. And the last one being very severe, what was it? Now I think the discussion has to become very wide. Also, Rajesh, we may ask them the causes of recurrent abdominal pain, so that in case they are asked in the examination, they'll be able to answer properly.
Yeah, I agree. The present episode may be the significant episodes. Previous episodes, as Madam told, might have been the recurrent pain of childhood. So, how much weightage you give to the previous undocumented episodes, no? Is also so, because when you only emphasize only one, or as if you only want to say it's pancreatitis, no, it makes it a bit shaky, no. So, it's better to keep wider possibilities and discuss as multiple episodes, which may not be significant. Present episode is the like an acute pancreatitis or some acute episode. Yeah. So can you give some other causes for pain apart from what you mentioned? You're given biliary. Can you come to that slide which you gave the biliary? No, next slide. Yeah. So pancreatitis, colic, we discussed. So you mentioned gastric outlet obstruction. So from the history, have you given any history which suggests gastric outlet obstruction?
No, sir.
Is there anything in the history to suggest gastric outlet obstruction?
at times he had this
He
postprandial
had only 2
bloating.
bouts of vomiting in the last attack, no?
Yes, sir.
So is it and it was not described properly? I have said no. You have to describe the details, including the volume of the vomiters, the characteristics of the vomiters, whether any symptoms are relieved, all those things. So in the absence of that, if you say gastric outlet obstruction, you'll be dragged into dangerous territories and they will keep on asking you questions. So if you are not so sure, please don't say. And especially annular pancreas may be okay, acceptable, but gastric outlet obstruction is. How do you explain that vomiting? 2 episodes of vomiting. I think if you listen to the last class, which was on Thursday, this was discussed. When do they get pain in acute pancreatitis or acute exacerbation of chronic pancreatitis? Very often, when a patient has got an inflammatory lesion of the upper GI tract, they may vomit during the episode of pain, especially when they eat. This may be due to inflammatory edema of the gastroduodenal area, androduodenal area, there may be there, or it could be partial obstruction due to bulkiness of the head of pancreas or a pseudocyst or a collection, which we discussed in the last Thursday class, no? The same discussion was there, causes of vomiting in a patient with the acute pancreatitis or a pancreatic illness. Okay. Now, just 2 bouts of vomiting. I think it will be little far-fetched to make a diagnosis of outlet obstruction. Now, do any other differential diagnosis, Dr. Dheeraj? Do you have any other DD? Your diagnosis is recurrent acute pancreatitis.
Give a differential away from the pancreas, and then come down to pancreas. What are the other causes of recurrent abdominal pain in childhood? Because he's 14 now. He's 14, Crohn's disease, 14 years now. 3 years means he is just about 11, 14, 11, no? He's about 11 years, no? Yeah, so 11 years is a very young age, no? How often has he absented from the school? Those are the things that we need to know. Because of the pain, how often was he absented? How often he had pain at night? Did it wake him up at night? Any of the episodes, did he have pain at night? These are the things that will tell whether it's organic. I think if the history is good, you'll be able to make just a different, very good differential. I've already discussed some of them. Lead, then porphyria. These are some of the other conditions where you have recurrent. But first, I'll think of functional disorder. In this particular case, if the appetite is good, weight is constant, and you mentioned malnutrition in the summary. I do not know how you picked up the malnutrition in this patient. Yeah, worm infestation with present. That's the most common cause. Dr. Madana Gopal.
Worm infestation, agreed.
Dr. Madana Gopal would first give a deworming. Any patient with recurrent abdominal pain, he first deworm. That's the first diagnosis.
Can this be intussusception? It can come and go. It can come and go. Sometimes it may be severe recurring hospitalization. Okay. Can this be appendicitis? The pain can be referred over the periumbilical area, and this time it was severe enough, and the patient got hospitalized. Appendicitis need not be always associated with the high-grade fever. Okay, when there's an abscess formation, there could be. When there's an abscess, appendicular abscess, there could be. But even then, it's not necessary. So,
yeah, just one comment. When a question like that is asked, don't say but, just say patients with acute appendicitis would present in this manner. Okay? Yeah, just you have to, don't take, but the patient did not have fever. So in other words, when sirs asked you, it can be acute appendicitis, and you say acute appendicitis usually presents with a pain in periumbilical going radiating to the back. Most of the times, once again, the patient would have just 1 or 2. There's nothing called subacute appendicitis. It is usually an acute appendicitis. And if it's a true appendicitis, the pain would disappear with surgery. So that's how you answer, okay? Instead of giving, don't start with the but the patient did not have fever. I'm just trying to help you out how to present it, okay? So answered most of the, whatever he wanted to convey. So the answer is what sir said. But when you reply back, reply in a positive way. Patients with acute appendicitis, then they'll ask you what is referred pain, and then you go in the direction, but it's okay. Yeah.
Yeah, it is not an argument. It is a sort of a discussion. Yeah. Understand the difference. Okay. And can this be simply recurrent abdominal pain of childhood? What is the cause of recurrent abdominal pain of childhood, children or adolescents?
Central sensitization, sir.
Pardon?
Central sensitization due to the recurrent functional pain, abdominal pain.
Mostly it is, somebody said mesenteric lymphadenitis. How often do you think is mesenteric lymphadenitis related to abdominal pain?
Yes, sir. TB is common in children, and Yersinia infection also can be considered, sir.
Pardon? TB is common.
TB, sir.
Which one?
Abdominal TB, sir.
How many abdominal TB you have seen in the last 3 years in below 15?
And presenting as recurrent abdominal pain,
Recurrent abdominal pain.
not even one patient.
See, the most common cause of mesenteric lymphadenitis is still unknown. It is presumed to be due to some infection, and somebody also hypothesized that it could be due to the equivalent to the primary complex which is happening in the intestine. But the biopsies of these lymph nodes have never yielded any positive result. Always showed non-specific lymphadenitis. So the recurrent abdominal pain in the pediatric practice could be due to organic disease, could be due to functional disease. The organic diseases which I mentioned earlier, like appendicitis, worms, porphyria, lead poisoning, and all those things. Okay. The functional ones are the ones which is much more common, and only after thorough investigation we will tell them, because mostly the pain is intermittent, self-limited, doesn't require any urgent hospitalization or injections. Mostly nocturnal pains are absent. Some defecation disorder like constipation may be present in most of them. And abdominal ultrasound mostly shows enlarged lymph nodes, which are subcentimetric mostly, and we don't know the real pathology because no pathology has been attributed. It's always a red herring. Doctors say that there are lymph node enlargement, but this relationship pain, I think, is not well described. Professor Rajesh, have you come across any article regarding this? Because I have been also been reading about this.
Yeah.
I am totally at a loss to find out whether the abdominal lymph node enlargement has anything to do with the recurrent abdominal pain of childhood.
No, yeah, I think you're right, sir. It's not very convincing. That's the same.
Yeah, the entity is there, but its exact cause and its natural. Very often, it is this seems to be lasting for about 6 months, and gradually these lymph nodes settle down. Okay, whether it is, I won't say it is not the cause, but I would say we do not know much about this entity. And one problem which I have noticed in today's discussion is that the diagnosis, everything, the history was tilted towards pancreatitis, and the diagnosis, everything was tilted, the summary and the first diagnosis, everything is tilted towards pancreas. Once in the mind, if you get sort of biased towards pancreas, even other differential diagnosis will not come. You won't think. This is called hovering around one diagnosis. So that should not happen. So even if you think definitely that it is pancreatitis, still you must be able to offer some other differential diagnosis and negate it immediately. I don't consider the possibility of appendicitis. I don't consider biliary disease. I don't consider intussusception. Like that, you must be able to say, okay, then the examiner will be definitely impressed. Anything else to discuss in the history, Professor Rajesh?
So I think, sir, we can proceed, sir, to the examination.
So we can proceed to physical. Okay.
Physical
Okay, read
examination.
out, please.
You said
Patient
malnourishment and weight is 50 kilos, sir.
I said no malnutrition.
No malnourishment. Okay, please.
Physical examination. Patient is conscious, oriented to time, place, and person. Height is 155 centimeters. Weight is 50 kilograms. BMI is 28.8 kilograms per meter square, which for his age, it's above the 50th centile. Meter upper arm circumference is also 22, which for his age is again above the 50th centile. The heart rate, his vitals, the heart rate was 80 beats per minute, regular, nominal volume and character. Peripheral pulses were well felt. The BP was 110 by 70 millimeters of mercury, right upper arm supervision. Respiratory rate was 18 cycles per minute. He abdominal thoracic. Icterus was present. There was no pallor
Icterus was
clubbing.
present. Okay, icterus is there.
Yes, sir.
There's significant finding, no, in interest, you say.
Yes, sir.
So that is not in the history, no? History of jaundice.
No, sir. He didn't give history of yellow discoloration or high colored urine. There was no history of jaundice.
Okay,
Even the
okay.
bystanders also have not noticed.
No, sir. They didn't notice. No, sir.
Yes, sir.
There is no pallor, clubbing, lymphadenopathy, or edema, fetal edema.
How deep was icterus? How deep was icterus?
It was
How
Is it
deep
very
was-
mild icterus or
It was,
it is
it was mild.
significant
It was
icterus?
mild icterus. It was only mild icterus.
It was mild icterus. Okay. Okay, if it is deep icterus and if that is not mentioned in the history, there will be a lot of questions. Okay. Mild icterus, okay, no problem.
During examination that time, RT was in C2. At teto examination, there was no bite or spots, no rash, no oral ulcers, no ecchymosis. He had an IV cannula and he also had a patch over the left lower quadrant. It was an anesthetic patch. Otherwise, general examination, GI examination, oral cavity was normal. Inspection of the abdomen, abdomen was flat.
You
Umbilicus
just
was,
move forward. Everything is normal, no? You just move forward.
he had tenderness over the epigastrium and right hypochondrium. There was no hepatosplenomegaly. Percussion tympanic note was heard. Trough space was resonant. Bowel sounds were heard normally.
Is there anything which is abnormal on physical examination?
Other than the icterus and epigastric and right hypochondrial tenderness, nothing, sir.
Okay, okay.
So I'll just make a comment here. Don't use the word hepatosplenomegaly. Just say liver was not palpable, spleen was not palpable, trough space was resonant.
Okay, ma'am.
Okay. Will you examine other systems in this patient?
Yes, sir.
Is it just routine or is it specifically look for something?
We're considering pancreatitis.
Which
sir.
system you want to look specifically?
Respiratory, sir.
Respiratory system. What do you look?
Intensity of breath sounds, air entry. There could be a concomitant
Okay. So what is in your mind? What
pleural
pathology?
effusions. Pleural effusions.
Pleural effusion. Yeah. Sometimes pneumonitis can occur, but mostly it is pleural effusion. And where do you get it mostly? Which side?
Usually left side, sir.
Which side? Left or right? Left.
Left, sir. Yes.
Mostly it is left.
Yes, sir.
Okay. The other systems are normal. So after
Okay.
physical examination, apart from icterus and tenderness, there is no other physical finding. So do you want to alter your diagnosis now?
I would still consider the same differential, sir.
How do you explain the icterus then?
If at all it was of a pancreatic pain, sir, currently because of a complication, there could be a worsening of the intensity of the pain.
No. You have to tell me exactly why there is icterus. What is
Uh,
happening to the biliary tree? Is it a parenchymal liver disease or it is a biliary disease?
biliary
In
disease.
addition to so-called pancreatic illness.
Biliary disease in addition to a pancreatic illness.
Pardon?
Biliary disease in addition to a pancreatic illness, sir.
So you think there is a biliary disease in addition?
I say it is Gilbert's. I say it is Gilbert's. I say it's hemolytic anemia.
Naveen and Dheeraj, do you have any suggestions? Because there is interest, do you want to offer any differential diagnosis? Pardon? Yeah, it was not mentioned, so we presume it is not there. With icterus and this history, do you want to add anything? But do you think this is, if it is a stricture of the biliary tree producing cholangitis, don't you think that, and especially with the illness lasting for 3-4 years, don't you think that the patient would have developed jaundice or something like that, history-wise itself? And biliary stricture, what do you think is the cause of the stricture then? Secondary to chronic pancreatitis, biliary stricture and jaundice due to that. Okay. Okay. Any? Naveen?
What will be the urine color if the patient had a stricture? But it said the urine color is normal. Then when do you get a normal colored urine with a jaundice? What are the causes? Then would that not be your first differential? What about Gilbert's? So see, you yourself mentioned patients got icterus, but the urine color is normal. So in that context, what are your differentials? So one is hemolytic, the other can be Gilbert. So urine color will be normal. So if it was hemolytic, did you ask for any other questions that you asked? Whether the patient had fatigue, there was tiredness, was there any other thing that he had? And therefore it was more like hemolytic gallstone disease. And therefore it is a recurrent gallstone disease. And then he has this problem of recurrent acute pancreatitis. This is a way, this is the way you have to consider, be very careful when you're mentioning certain statements. You said icterus is present, you said it's mild icterus, and you said the urine color is normal.
Okay, if the urine color is definitely normal, it will be difficult to even diagnose biliary disease. It has to be hemolytic disease or Gilbert's.
I would ask the patient to pass urine in a test tube and bring it and show it. That's the best way, no? You want to confirm. Yeah, that's the best way.
I think the presence of jaundice, suddenly there will be an array of questions to you because there was no discussion on that part in the history, from the history. So if you have noticed icterus, it would be wiser to ask some questions which is very important like this, no? History of pruritus, which was not obviously mentioned, and color of the urine. These things will be definitely asked by the examiners.
Yes,
so once there is icterus, one must be extremely careful to ask some of these points and present it in the history as a negative history. Professor Rajesh?
Yes, sir. When you notice icterus, you should have taken some more history, added those points, and clarified whether there is any history related to biliary disease, or as Madam told, hemolysis, all those things. Because it looks as if suddenly the thing has come up in the examination. So since there's no other physical findings were seen. So definitely, even if it was not mentioned in each, you should have gone back and taken the history before presenting, when you revise the history accordingly and then present.
Yes, sir. Okay, sir.
Also, you mentioned that the bowel sounds were normal, no visible peristalsis, all those things you mentioned.
Yes, sir. Bowel sounds were normal. Yes, sir.
In intussusception, can you expect any physical finding? In a case of intussusception, do you expect any physical findings, at least intermittently? Sausage-shaped mass may be there in the abdomen, which may appear and disappear.
Neeraj? Yeah,
I think these things are not discussed in adult gastroenterology, so that is why people are keeping silence. So if you get an adolescent case, a lot of questions can come out, abdominal pain in child. And I think you may have to read your Bayesian law also and DAS also to update yourself regarding various causes. Okay, and presentations. Can we now go to the investigation part, Professor Rajesh?
So what's his diagnosis after the examination?
Because none of them have offered any diagnosis, any more diagnosis after physical examination. I asked each of them.
Once jaundice has appeared, you have to give a differential now.
You have to give an explanation. So first we will ask the presenter. Swaran, because of the presence of jaundice, what is your final diagnosis from the history, or a list of differential diagnosis from the history?
Sir, now due to the
you have put it here. You can read it out. You have two diagnoses.
Yes, so it still could, because of the change in the intensity of the pain and current presentation with icterus.
No more discussion, doctor. Just tell what is your differential. Don't keep on discussing.
You have already put it in acute and chronic pancreatitis with the biliary obstruction. What is there in the history or physical findings to say that this adolescent boy is having chronic pancreatitis?
Biliary obstruction and biliary obstruction.
And chronic pancreatitis, biliary obstruction. What is there in the history? Agreed that there could be abdominal pain, which is severe enough to take injection, all those things, and it could be recurrent pancreatitis. Up to that, we agree. But what is there to say it is chronic pancreatitis?
Multiple episodes of pain, sir.
Okay, we can call it recurrent episodes of pancreatitis. We do not, it could be, and one of the presentation of chronic pancreatitis is recurrent acute abdominal pain. Okay, that way we can explain it. But what is there to say that is biliary obstruction?
History-wise, nothing, sir.
History-wise?
Nothing is there, sir.
Nothing is there. So one should not put it diagonal. If there is nothing, one should not boldly put it like this, because you will find it very difficult to defend. The examination is the day when your future is decided after 3 years. No? So whatever you utter will be considered with importance by the examiners, and they will assess your general knowledge in gastroenterology. So you have to tell with very carefully. And the second diagnosis is recurrent biliary colic with the cholecystitis. What is there to say that there is cholecystitis?
So the fever, right the right epigastric and the right hypochondrial tenderness with the fever. I just thought cholecystitis also could be a possibility.
So right now, do you think your patient has got cholecystitis? Does he have Murphy's sign positive?
There was tenderness, Murphy's sign.
But tenderness was there everywhere in the epigastrium, no? Not only in the Murphy's area.
Yes, sir. Epigastrium
So
and
Murphy's sign. What is actually Murphy's sign? Is it elicitation or tenderness or something else?
It is an inspiratory catch, sir.
Was it present?
No, sir.
No, it was not present. Okay,
No,
there was only tenderness in the Murphy's spine, but you have tenderness of almost all part of the upper abdomen, no?
Yes,
So
sir.
then it doesn't become very relevant. Okay, we can perhaps say that this cause of recurrent pancreatitis could be maybe due to biliary disease. As ma'am said, it may not be due to cholelithiasis, it may be due to sludge or microlithiasis. That's the way you can explain. Okay, now, Professor Rajesh, your suggestion or your comments on the diagnosis?
I think rather than say acute and chronic pancreatitis, it's because the chronic pancreatitis, from the history, it's not that definite. So better to say is recurrent acute pancreatitis with possible underlying chronic pancreatitis. That's a better way to do it. And
Okay,
also, only thing is this jaundice, which is mild, but no other definite symptoms or signs to suggest individual obstruction.
So what I would do is I would give a differentiation for recurrent abdominal pain, and then I'd say I would like to discuss the jaundice in this patient. It was an incidental finding, and putting the jaundice in correlation with the recurrent abdominal pain. These are my differentials. If I have to disconnect the jaundice and the abdominal pain is totally distinct away from the jaundice, then my differentials would include 1, 2, 3, 4. So then you will not be wrong. So you have one connected and one disconnected. So whatever be the investigations, you'll either get a connection or you get a disconnection. So always say at the end of this, you're in for a surprise. There is jaundice. So you say, I would like to discuss on jaundice in this particular patient. And then say the jaundice in this patient appears to be maybe hemolytic, maybe Gilbert's, because the urine is normal. I asked him to pass urine. And when I saw the color of the urine, it was just a pale yellow near white. So he does not have a cholestatic jaundice. That's it. I would do that. I would do that even in clinical examination. Ask him to pass urine and get me the tube and show me the color. And in absence of pruritus, in absence of cholangitis, in absence of any other features, it seems to be non-cholestatic. And if it is hemolytic, then recurrent stone disease can be there. And there can be possibility of a recurrent stone disease presenting as hemolytic anemia. And he has stone disease, and maybe he's got chronic pancreatitis. And maybe, I'm going a little further out, sickle cell disease with splenic vein thrombosis and chronic pancreatitis. I'm just thinking wild. You have to be wild. You have to be wild in your thought process when jaundice has appeared all of a sudden. All of a sudden, because and then as both the faculty members were mentioning, you have to go back and probe. Once you got the jaundice in the history, go back in the history and ask, what is the color? What is there pruritus? Is there itching? What is the color of the stool? You have to get into the depth of that because it's out of the box that you found something that was incidental. Or does he have a liver abscess and that is responsible for the pain? These are the things that you should think. There's history of fever for 2 days. So is it actually liver abscess that is actually presenting with jaundice, or is it granulomatous hepatitis presenting with jaundice? See, once you consider all the possibilities, you cannot get any further information from the investigations. You have to be dot on the history in 80%, 85%, you should be right on your history taking. So my differentials would be something in the parenchyma, but first would be if the color is normal, I think of hemolytic, then I try to see how hemolytic is caused pancreatitis. Second, I think Gilbert's is a possibility. So these are only two. Even in Dubin-Johnson, bile pigment is positive. Dubin-Johnson, Rota will not come as a DD. But Gilbert's can come as a DD. Crigler-Najjar type 2. Crigler-Najjar type 2 again will not have. They'll again be unconjugated hyperbilirubinemia. And suddenly you'll find out of the box, bilirubin is 19 and direct is 1.2. Be in for surprises. Because when you give a surprise message like this in your history taking, one thing we know that you do not know the investigation. So we are happy with that. When that is the situation, this is how you would discuss. My differentials for the pain are these. The jaundice is found on the examination, and even on cross-questioning, I'm getting that the urine color is normal and there are no cholestatic features. So my differentials for these are these. To link up the two, I would consider these differentials. To de-link the two, there can be wide differentials for the jaundice and there'll be wide differentials for the recurrent abdominal pain. I think it's the way you put it across when you speak. And please do not, that's very, very important, do not hang on to pancreas and pancreas and pancreas all the time. Porphyria can present with recurrent abdominal pain. Porphyria can present with hemolysis. Porphyria can present with jaundice. Porphyria cutaneata can present as hepatocellularcarcinoma in children. Look at the wide differentials that are coming up. Liver abscess may be one of the findings in this patient. So doctor, just please keep a wide differential, have a wide differential for all that you're speaking. And please do not keep on. Then they will say, I think you know the diagnosis. No, why are you hanging on to pancreatitis? As someone told you, it's acute and chronic. That's how they answer. And then you will not know how to reply back, because you would have truthfully done it. But the examiners will think, why is this boy hanging on to only pancreas all the time? These are my personal experiences in the exam. All three of us have been examiners. So we are trying to give the best information that we can so that you have just a cakewalk in the exam. Okay.
Yes,
Can we move on to investigations? Yeah.
We'll ask Naveen, how you plan to investigate?
So because
Just tell us the plan of your investigation and the rationale.
I would like to do first hemogram, sir, to look for any hemo concentration and PCV, because one of the DD we are considering is biliary pancreatitis this episode, and to look for any leukocytosis, which could be a part of SIRS, or it could be a part of infection, as liver abscess also is one of our DD, and thrombocytosis as a part of inflammation, and SIRS. I would like to consider do LFT also, sir, to look for the total bilirubin direct is elevated or not. Look for the enzymes, because one of the biliary is our etiology, to look for the ALP levels elevated or not, along with GGT. And
usually, how much will be the elevation of ALT, AST in a biliary pancreatitis?
So usually 2 or 3 times, sir, in a passed out stone, sir.
Okay.
ALP and GGT, whether they're elevated or not, sir. And for amylase lipase, and because it's a recurrent abdominal pain, we're thinking of some metabolic causes also for the pancreatitis. I would like to ask for serum calcium levels.
You said amylase and lipase. Is there a need to do both?
No, sir. Lipase is more specific. Yes, sir. But to diagnose amylase, one is enough, sir. To diagnose.
Is there any need to do amylase then? Why do you
but
ask
amylase
for amylase and lipase together? What is the problem? When do you ask for amylase? When do you ask for lipase? Or do you only ask for lipase?
Sir, lipase is more specific, sir, to define pancreatitis, whereas amylase is non-specific.
Is more sensitive.
Yes.
Okay. Anything more?
If we are thinking some other DDs along with pancreatitis with like a precipitating factor like DKA, amylase also will be elevated in DKA. In that situation,
okay, two problems with amylase is that one is it is a non-specific elevation. There are empty number of conditions in the GI tract which can produce, and elsewhere also, which can produce elevated amylase. Second, the peak of amylase elevation is the first 24 hours. After that, it falls.
Yes, sir.
Especially in acute pancreatitis, there seems to be an enhanced clearance of the amylase by the kidney. So the level falls. So that is why many people in the olden days used to look for urinary amylase and diagnose pancreatitis. Regarding lipase, first more specific. Second thing is it lasts for a longer period. The two reasons are there. Am I right, Professor Rajesh?
Yes, sir.
Doing better than
yes, sir. Yes.
So it's a habit that we say amylase lipase. So you must be able to tell the reason for it. Okay.
Okay, sir.
Yes, continue, please, Naveen.
I would like to ask for serum calcium levels and serum triglyceride levels also, sir, because we are thinking of metabolic cause also for the recurrent abdominal pain. And ultrasound abdomen. So next,
what will be the usual triglyceride levels? Is it in just 200, 300, or
no,
is
sir.
it 800,000 like that?
It should be more than 1,000 to cause pancreatitis.
Yeah, usually it will be severe hypertriglyceridemia. There also it is said that don't try to do it in the acute phase. Maybe do it once the patient recovers. Okay.
Yes, sir. Because one of our DD is our chronic pancreatitis. I would like to do FBS, PBBS, and HbA1c also, sir.
Which one? Which one?
Fasting blood sugar, postprandial blood sugar, and
Okay, okay.
HbA1c,
The
sir.
sugar profile. Okay. Glucose profile. Okay.
Then I will proceed to do an ultrasound abdomen, sir, to look for the gallbladder distension or pericholecystic fluid or any wall thickening or any dilated CBD. And if there is a good window, I would like to see pancreas also, even though it is not a good modality for evaluating the pancreas.
Okay. Next.
So depending on the finding, if you are not able to find, I would like to consider a cross-sectional imaging with an pancreatic protocol, sir, which includes a contrast CT with 2 arterial phases and 1 venous phase.
What's the ideal timing of doing a CT scan in a patient with suspected acute pancreatitis?
After 48 hours, sir.
Why do you don't do it? Because you want to have a diagnosis. The patient has reached ED and they don't have a diagnosis, and you are waiting 48 hours. Mean you don't have a diagnosis, no? So why do you wait for 48 hours?
Because the chance of developing complications in an acute pancreatitis, it takes at least 48 hours to develop, sir. So for the better evaluation, contrast CT can
Which
be done after.
complication you are mentioning? There are empty number of complications like collection, pseudocyst, abscess. So which complication you are expecting at 48 hours?
Sir, vascular complications like splenic weak thrombosis, sir.
No. Be very clear. We want to assess the degree of necrosis.
Necrosis, yeah, sorry, sir.
Because in the first 48 hours, the assessment of necrosis by CT scan will not be complete. Because by doing a CT scan, we want to assess the severity. We want to do the severity index and find out how much necrosis is there. Because that gives the prognosis of the patient in acute pancreatitis. How much is the necrosis? Okay. So that can be found out only if it is done by around 48 hours. If you do it in first 24 hours, you may miss the acute pancreatitis. Second, you may miss necrosis completely. Okay, and rest of the other complication like venous thrombosis and all those things, if it is present, can be picked up. Okay, fine. That is only additional findings. But we are mostly bothered about first making a diagnosis and two assessing the severity of the acute pancreatitis, for which 48 hours. Is there any risk of doing contrast enhanced CT scan in acute pancreatitis?
Yes, sir, because they are more prone to, in a severe acute pancreatitis, they are more prone to develop organ dysfunction also, sir, multi-organ dysfunction in the form of AK also, sir, due to hemoconcentration.
There were some papers, but I think that is not considered, important contraindication for any CT scan. Some apprehension whether it actually increases the infection, induces renal failure, etc. But I think those apprehensions have been overruled by further studies. Am I right, Dr. Professor Rajesh? Do we have still any inhibition of doing CT scan in the first 48 hours?
Yes, generally the thing is unless it's required, there is no need to do the CT scan in the first 48 hours. So that is the general principle which we follow.
Yeah, if our diagnosis is doubtful, whether we want to have a biliary complication or something, we are not so sure of pancreas, then we'll have to do it before 48 hours or even first 24 hours. If you are fairly confident it is pancreatic, then do it at 48 hours. Okay. Okay, now you interpret what is available.
Yes, sir, in this
Just
patient,
go through it fast and
yes, sir.
Stop at relevant points.
Yes, sir. Hemoglobin is low with no leukocytosis or thrombocytosis, and CRP is elevated 98. Sir, lipase is elevated more than 3 times, so 1405. Calcium and triglycerides are within normal limits, and liver function test showed an direct hyperbilirubinemia, sir, with elevated enzymes of AST ALT along with ALP, sir, 286, with normal albumin and globulin without age reversal, with a normal INR and.
So this is conjugated or unconjugated?
Sir, it's conjugated, sir.
Okay. So what is your overall impression about that liver biochemistry?
So probability could be an choledocholithiasis.
I couldn't hear properly. Can you be a little louder?
Could it be an choledocholithiasis, sir, or an acute severe biliary pancreatitis with the bulky pancreas obstructing the distal common bile duct, sir?
Okay.
SGP 112 is huge, no?
Yes,
you don't get that levels in biliary obstruction. 512 is huge. You have to take history of CAM and other things. Just be very careful with that. You normally will get an 80 to 100 if there's a choledocholithiasis.
Is this alkaline phosphate elevated?
Yes, sir, 280.
Alphos, is it elevated? IU?
He is an adolescent. He may still be
Adolescent.
Yes,
Yeah.
That
yes,
is
sir.
the catch.
Aging, yes,
which
sir.
I wanted
Aging,
to ask.
yes,
Catch
sir.
question. In an
Yeah.
adolescent, be careful when you interpret about alphos, because
Yes.
alphos will be high in growing age.
Adolescents, yes, sir. Growing age, bones.
Okay.
Therefore, you need a gamma GT.
Yes, sir.
Yeah, gamma GT is not there. Okay. Show the
Next,
next slide, please, Saran.
This was just a serial LFT, sir. Before this, we had got the ultrasound done.
Okay.
ultrasound shows a normal liver with CBD dilated, sir, at 9.5 mm at the hilum, and the CBD is dilated throughout the entire course with some few Cori calculi in the distal CBD, with largest measuring 10.5 mm. Bilateral IHBRD is there, and the distended gallbladder with echogenic sludge, thickened wall, and a fat standing also is noted. Diffusely heteroechoic pancreas with multiple foci of parenchymal calcifications with dilated main pancreatic duct of 11 mm with intrarectal calculi and a normal spleen.
How much was the CBD dilated? How many millimeters?
9.5.
9.5.
5.5 centimeter. Huh?
9.5 mm.
9.5 at hilum.
CBD 9.5 millimeter at the hilum. Huh? That's dilated. 0.9.
9.5 at hilum. Lower end they have not mentioned, but lower end they have mentioned as a calculate 10.5. So
No, but they've-
obviously
no,
the
but
lower
they-
end CBD must be about 10 millimeters.
So they've written CBD dilated in the entire course. Is it choledochal cyst? It is dilated through CBD.
Yes, ma'am. Could be possible, ma'am, because in recurrent abdominal pain, we are thinking of pancreatico-biliary malunion, which is usually associated with choledochal cyst also, sir. Ma'am.
Any other possibility you'll consider when you have this higher
Maybe
level?
if you
AST?
have a patient with the choledochal cyst type 1 and CBD calculi, how will you differentiate on ultrasound? Usually IHBRD will not be there.
Yes, sir. If choledochal
If
cyst.
IHBRD is there, that means there is a
Choledochal
blood
lithiasis.
pressure on the intrahepatic system also. In most of the cases of the choledochal cyst, unless you have intrahepatic component, which is also cystic like, IHBRD is not a feature of the ordinary case of choledochal cyst. So if you have a dilated CBD with the IHBRD and the stone, it's most likely to be due to choledochal lithiasis. Is there anything else in the gallbladder?
They have mentioned some echogenic sludge, sir, with a thickened wall and fat standing also, sir, suggest of cholecystitis.
Thickened wall is there.
Yes,
So
sir.
what is the
They have not-
relevance of finding an echogenic sludge and a thickened gallbladder wall in a patient with suspected acute pancreatitis?
It can imply that the pancreatitis etiology is in biliary pancreatitis, sir.
So in a
Pancreatitis.
patient with a severe acute pancreatitis, there could be edema of the other organs of the upper GI tract. Therefore, some degree of edema of gallbladder wall may occur. If it is
Yes, sir.
very significantly thickened, it may be considered significant. What about sludge?
Sludge also can cause pancreatitis, sir.
Yeah, sludge may be the cause, but also may be the effect. In a patient with a severe acute pancreatitis and the patient is denied oral food, there could be stasis in the gallbladder and they can have sludge also. So finding a sludge in a patient with acute pancreatitis, you should not jump on and diagnose a microlithiasis. Actually, you should subsequently do further evaluation and find out whether it is sludge, because an acute pancreatitis itself can induce a sludge formation. Okay.
Sir.
Now regarding pancreas, what is the finding?
Diffusely heteroechoic pancreas, sir, with multiple foci of parenchymal calcifications and also an intraductal calculi with an associated dilated main pancreatic duct.
Which one?
Multiple calcifications are there in the parenchyma as well as in the main pancreatic duct.
So what is your diagnosis regarding pancreatic illness?
So after these findings, I would say it could be a chronic pancreatitis, sir.
So this is chronic pancreatitis.
Yes, sir.
But we don't find any features of acute illness here.
Yes, sir.
So is it that it's only chronic pancreatitis and there is no acute component?
Yes, sir. There is no acute component like peripancreatic fat standing or
Actually, the
pancreatic
acute
collection.
component may be completely missed on ultrasound. Ultrasound is insensitive technique. He could still be having an acute exacerbation and we may miss it on ultrasound. We may only see the original disease. Okay.
Yes, sir.
So in which case, what will you do next?
Cross-sectional imaging, sir, with a pancreatic.
Okay. Do we have Saran?
Yes, sir. We actually planned for MRI, MRCP, but couldn't get
Do
a
we
slot.
have a CT scan?
Yes, sir.
Why do you want a cross-sectional imaging? What is the plan? You've already picked up CBD dilatation, you picked up the stones, you picked up the pancreas, you picked up the stones in the pancreatic duct. Now, why do you want a cross-sectional imaging? For what purpose?
Yes, ma'am. With an ultrasound, we have confirmed that it's a chronic pancreatitis. So it's an already 3 years of the disease from the onset of the pain. We should also think of complication as a part of chronic pancreatitis in the form of malignancy, which can be picked up in an
Malignancy.
in this patient, 3 years.
very less.
15-year-old patient, 15-year-old patient, 3-year illness.
14-year-old boy.
Uncommon, ma'am. It takes even more than 5 years of the disease to
Here
get
we
risk
ask
for developing pancreatitis.
what is your plan now? What is your plan in this patient now? Would you, is this sufficient for you to manage, or what is the need for one more imaging? And what would be the best that you would do? You know, you have EUS, you have CT, you have MRI. What is the best imaging and why?
Yeah.
You have to why you need any of these imaging procedures. Patient is in pain, and patient has got a high lipase.
So first, initially, I would treat the patient, ma'am. Once he's pain-free, I would like to consider an MRCP, ma'am, non-invasive investigation rather than contrast CT.
Obstructed, if there's a stricture, he may not get obstructed and he may not get relief of pain at all.
Naveen, ideally what you should say that ultrasound abdomen may not pick up all the problems related to acute or chronic pancreatitis. The patient may still have a fluid collection in and around pancreas, which may be completely missed by an ultrasound. Okay, so you want to study the problems in relation to the pancreas thoroughly by another cross-sectional imaging, which can be CT, MR, or EUS. All the three are possible depending upon availability and expertise. And then you have, because you have to plan out the treatment, you have to find out the cause for the pain. You have to find out the cause for the jaundice, which we presume it is due to the CBD stone. Okay. So before definitive treatment, we have to know exactly what is wrong and what level of disease the patient is having, all those things. So apart from ultrasound, I think we require a cross-sectional imaging. It's up to you to decide which is the best. Professor Rajesh, your opinion about further evaluation? Professor Rajesh? They are not able to hear.
The advantage of MR in younger patients generally is preferred because less radiation. Also, you can pick up any congenital anomalies like pancreas DVSM associated. There's better picked up on the MRCP rather than the CT. Other thing, what I would think in the ultrasound, you mentioned is a diffusely dilated CBD and a bit higher levels of AST and ALT. So one thing you can keep in mind is there's an ampullary obstruction. It may be a stone which is causing ampullary obstruction. Usually then you get a higher levels of AST, ALT, which will normalize more quickly, and you have a diffuse dilated CBD also.
Okay, sir.
Yeah. Especially when you have CCP, that is more common, somewhat more common. So can you read the CT?
This is an coronal section of an CT abdomen, sir, which is showing an distended gallbladder with gallbladder wall thickening also, sir, and then some intrahepatic biliary radical dilatation. Along with that, I can see a dilated CBD as well as a dilated pancreatic duct, sir, with some calcifications in the pancreatic parenchyma, sir, because there is an associated dilated MPD was built up in pancreatic duct calculator, but I can't appreciate in this the calculator.
Yeah.
The calculator also is there in the head region, lower part.
Sir.
Okay. Yeah, do you have other films?
I could load only the coronal, so the axial were not loading.
PD is definitely quite dilated.
I think shows the next.
Any other images? Okay.
So CT abdomen showed multiple calcific foci of varying sizes involving the head, body as well as tail, with a dilated pancreatic duct of 11 mm, with few intraductal calculi in the tail as well as head regions, no focal mass lesions or peripancreatic collections suggest of chronic calcific pancreatitis. And there is also an intrahepatic biliary radical dilatation seen in both lobes of the liver with CBD 11 mm in size and shows a smooth tapering and without any definitive intraluminal calculi or mass lesion.
Okay, there is
Distended
no definite intraluminal calculi or mass lesion. We have noted down. CBD is dilated, but there is no calculi in the CBD. The ultrasound has told us that there is a calculi of 10.5 millimeter. That was the issue. Okay.
Yes.
And gallbladder also doesn't show any calculi.
Yes.
Because if there is a chronic calcific pancreatitis and CBD calculi, two calculus disease occurring simultaneously is a strange occurrence. Can happen, I have seen it, but then it will be such a strange thing.
How do you explain the IHBR dilatation?
Ma'am, even though CT is not showing
Just asking
CBD
you, don't say not showing. I'm asking you what it is showing.
ma'am,
Just-
because ultrasound is more sensitive for that, I will
No,
consider
ma'am's
the
question
cholecystectomy.
is, what is the reason for IHBRD
I'm
in this
Just a
patient?
simple question, what is the dilatation in this particular finding? I'm not asking you about ultrasound or doctor.
Pancreatitis, bulky pancreas compressing the distal CBD, ma'am.
Any other possibility? Please do not be so abrupt in your answer. Just a request.
I would consider choledocholitis also, ma'am, because ultrasound is more sensitive to pick up the stones, even though CT is not showing it.
How often do you have a choledocholithiasis in the distal end presenting dilatation of the CBD and IHBR bilateral?
Yes, ma'am. Very uncommon, ma'am.
Is the obstruction in biliary calculi, common bile calculi, more severe than in a person with a neoplastic obstruction of the biliary tree, which is more complete?
Sorry, sir.
Do you understand my question?
No, sir.
You have obstructive jaundice due to a neoplasm of the lower end of CBD or a periambular neoplasm or C end of pancreas. The neoplastic biliary obstruction versus calculus biliary obstruction, which is more complete. Malignant biliary obstruction is more complete, except in the case of periambulary, which it may intermittently, the obstruction may be relieved. In choledocholithiasis, the obstruction is never complete.
Yes,
The bile actually flows along the sides of the bile duct, and bacteria also enter inside.
cholangitis.
That's why you get cholangitis.
Yes.
Understand? So, in a patient with the CBD calculi, extensive dilatation of IHBR is usually not that very commonly seen. There could be some other additional factor causing IHBR, which must be producing constant increased pressure in the biliary tree. Because choledocholithiasis only produces intermittent biliary obstruction, and whenever the pressure is high, it actually releases to some extent. Okay, we'll proceed. So from the CT finding, what is the diagnosis?
Chronic calcific pancreatitis with an distal CBD obstruction, sir.
Result, you think it is due to compression?
Yes, sir.
But the CT hasn't described any inflammatory or a mass lesion in the head, no?
Smooth tapering they have mentioned.
Pardon?
They mentioned a smooth tapering, sir, in the distal CBD.
Smooth tapering. So what is the most common cause of a smooth tapering in a patient with a chronic pancreatitis? It's a stricture.
Yes, sir.
Stricture is the cause. Stricture of the lower CBD. Okay, we'll proceed for it's already 9:30. Professor Rajesh, regarding
Yes.
management, we'll ask the next candidate how to manage this
Yes.
case. Next is Dheeraj. You can smoke extempore voluntarily. How you will manage?
Any other investigations? You don't need any other investigations, is it? Distal CBD obstruction. No other investigations, no endoscopy, nothing. No.
Dheeraj, you will have to say what all additional investigation you require.
Don't need anything. You're the gastroenterologist. You'll hand over the case, is it?
Do you want to assess the ampulla by it?
Why do you do an EUS? Why do you do an EUS? You have already a CT done. See, there is a discrepancy here between say ultrasound and CT, regarding CBD stone. So, and there is dilated CBD, and the CT is a less sensitive technique to detect a stone. That's another problem. So, in which case, another modality of imaging will be required to see whether there is any lower CBD stone, and whether it's any stricture, whether any other lesion, etc., etc. Okay. So you'll be able to assess the lower end of CBD, the pancreas, and very closely with an EUS. Okay. So how do you manage? Tell us the principle and what you do. What is the latest latest thinking of excessive fluid correction in acute pancreatitis? Earlier, we used to give 5 to 6 liters. What is the latest thinking on fluid replacement in acute pancreatitis? Is there a change? Yeah. Too much of hydration is not required. In fact, it leads to more complications.
Can you give an opinion about the severity of pancreatitis from the available investigations? So what about the HD? No, he has got microcytic hypertrophic anemia. No, slight leaks. Rather than yeah. What about CRP level? What is the CRP level of concern? I think it's 250. Above 150 CRP, no, in pancreatitis, you should be on the guard. No? Yeah.
What is the cause of pain in this patient? What will be the aim of management? One important thing, every center has everything. No, so answer, but if all facilities are available, what will be your choice?
No, So normally, what's the size of calculi where you opt for ESWL? It's not, yeah, yeah.
Just hold on to the pain. No, patient is not worried at all about this steatorrhea. For him, it's a pain. So your plan would be you will do ERCP for the biliary system. You place stents there, but he's not worried about it. He has got no jaundice. He's not worried at all about that. So would you have an MD consult and multidisciplinary consult with the surgeon, with the ESWL people, with the high interventional radiology people, and then take a call? Or would you consider that this patient is going to do well with an ERCP with ESWL, and you think he's going to get total relief of pain? We're not asking what are the pros and cons. We just want to know endotherapy. What is your aim? You said you'll do ESWL. Does he have a stricture towards this end, or have you documented there's a stricture in the pancreatic duct, or there's no stricture in the pancreatic duct? Mm. To tell you what is the cause for the double duct sign? No, that he's almost got a dilatation CVD and a dilatation pancreatic duct. Do we have any information on EUS or
No,
side
ma'am.
scope or side viewing scope? Any
No,
information?
ma'am. No, ma'am.
Side viewing?
No, ma'am.
Would you consider a side viewing scope at all in this patient?
Yes, ma'am.
I would consider, because both systems are dilated. Here there's a smooth tapering of this end. So I would definitely consider a side viewing scope, ensure that the ampulla is normal, and then take a call as to what is to be done. And he's also got stones in the parenchyma. It's not only the ductal stone. What are the chances of getting relief of pain after you do a ERCP? So these are the questions that will be asked. The outcome of your ERCP, what percentage will have pain relief? And if there's no pain relief, what will be your next step? These are the questions that will be asked in around this. So what percentage get relief of pain? You presume it's ductal hypertension. There's no stricture, so why should he have a ductal hypertension? That's why sir asked, what are the chances of you clearing that stone, that big stone, that large size stone? What are the chances of you clearing that stone? That's what we're asking. That large stone in the head region, what are the chances that you'll be able to do an ESWL and clear the stone? Dr. Rajesh, please discuss on these issues.
Professor Rajesh?
Yeah. I think what madam is asking is, what is the success rate when you're using ESWL or ESWL combined with endotherapy? Which is the better option? Actually, one with a young patient doesn't mean that you don't do surgery, but that's not a only way to decide, because actually surgery is a one-time procedure. So for a young patient, so that's also an option actually.
Yeah, until ESWL and endoscopic method came in, there was only one option, that is surgery for patients with severe pain. There was no other option other than analgesics, no? So now only you have one more option.
Yes.
So you have to decide which is to be done for which patient. So will ESWL and drainage will it help in all patients? Is there any problem? Because it depends upon how much strictures you have. One, whether how much of stones are there in the tail region. Because if there are strictures and lot of stones in the tail region, ESW you may be able to pulverize, but the stones will not be able to come out. So you have to pulverize and make sure that the stones also come out. No. Okay. And that does not always ensure that the pain will disappear, because the pain in pancreatitis is due to multiple factors. One is ductal hypertension, then parenchymal inflammation, neural inflammation. Many factors are there. So we are only assessing one aspect of it. Okay. But generally, if there is a dilated ductal system, large stones, and patient has got severe pain, it is presumed that there is ductal hypertension and some sort of procedure is done. Why are you interested in the head part? Because this is what there in the tail also, no? The maximum disease mostly seen in the head part in chronic pancreatitis. So the surgery, the procedure is generally head coring. Okay. Is that only coring of the head? Is there any drainage of the ductal system?
Ductojejunostomy.
Okay, that will take care of the ductal hypertension. Okay. And the head disease also taken care of by the head coring. Okay. And what is the success rate for relief of pain? Race procedure? Okay, you have to read up. You should know just the percentages. Okay. And
And what
just
family
yeah,
screen genetics you want to consider? You said one maternal uncle had gallstone, had pancreatitis or something. With what?
genetic test. Genetic test. What are the tests you will do?
And with what tension?
PRSS1 positive means what?
Hereditary pancreatitis.
Hereditary pancreatitis. It's a what type of dominance?
Autosomal dominant.
So if the grandfather had it, somebody in his parents should have had it, no? Because it's autosomal dominant, no? There is no such history. So it's unlikely to be that. Okay. Now, is there any genetic test for tropical pancreatitis? Well, these are associations. I have my own papers on all these things, but it is slightly more prevalent. Our study has shown that it is increased SPINK1 positivity in persons with chronic pancreatitis 3.5% or 3.5 times compared to the general population. But then it does not give us a diagnostic assessment, because it could be negative in many patients with the chronic tropical pancreatitis, chronic pancreatitis. So it is useful, but not for a diagnostic purpose. For research, okay. When you are doing a research on all this is okay, but PRSS1 fine. Okay, that the PRSS1 positive means hereditary pancreatitis, but other SPINK1 positive or CFTR, I don't think is it is still a research tool, not a diagnostic tool.
Yeah, it is not in the clinical guidelines. Only when you are suspecting hereditary pancreatitis, you first declare them.
The other 1 minute, like it's we're not, no, the management is over. The other important thing is this. I was just thinking, yeah, this is it idiopathic calcific pancreatitis, or is it chronic calcific pancreatitis, or just tropical calcific pancreatitis of how do you say that and why? What are the changing terminologies now? Please read Dr. Balakrishnan's paper. Okay, read Dr. Balakrishnan's paper. You have to read that paper for the changing terminology, and also read Pramod Garg's paper. And you
Why-
may
why-
you have
yeah.
to, and you have to speak on the antioxidant, okay? The one that is being patented by Dr. Pramod Garg. You have to mention about that. So read about that. Of course, diabetes has to be managed. If it is there, we will not really look into exocrine insufficiency. There is so much of pancreatic damage. We just manage him with change in diet habit. And you read about PERT also. All these things they'll ask. Role of PERT in management of pain. Apparently there's no steatorrhea. So I think that's the way it should conclude.
And what is there a role for PERT in the management of pain?
Pain, yeah.
Basically, you
What
have to
is
use a protease content. That is the key thing. So when you're using for pain, is the protease. What is the mechanism of action?
Okay, when you give hexacrine pancreatic supplements, what are other additional precautions you should? When is it given? Before meals, along with meals, after meals? Do you have to give any other drug? So when you give PERT for pain relief, when you give PERT for steatorrhea, is there any difference in the type of preparation? Okay, that is regarding the presentation of the medicine into the stomach. Is there any difference in concentration of enzymes?
Lipase concentration is more when you give for steatorrhea, sir. Whereas
Yes,
the
correct.
protease concentration is more for pain.
Okay, correct. Okay, that's the difference. Okay,
You have
and
there are 4 studies, of which only one is randomized control study on relief of pain. So pain management with the PERT is really not recommended.
yeah, that is it.
Yeah, so you have to read all the 4 papers. There are only 4 landmark papers, of which one was a randomized control trial, which gives some information saying that there may be a role. So you must know the studies, and we usually don't recommend treatment with PERT for management of pain. Okay.
Cochrane analysis of the effect of PERT on pancreatic pain actually says it is negative. Okay, so it is a controversial subject. You can be neutral. You don't have to side with anybody. In an examination, you say what is there in the literature. That's it. Okay. It was initially given with the hope that it works, but Cochrane analysis has subsequently come out with the statement that and it is probably of not much use. Okay, so when you give a uncoated tablet, it is likely to be destroyed by the stomach, and therefore usually PPI or H2 blocker is also given to okay. And one of the side effects of long-term pancreatic enzyme therapy,
Colopathy, sir. Colitis, sir.
pardon?
Colitis.
Fibrosing, yeah, fibrosing.
Is it colitis or?
Yeah.
Fibrosing
Okay.
colopathy.
Fibrosing colopathy plus hyperuricemia, because it is actually the nucleus of the cells of pancreas, which is and the extract of that which the person is taking. So hyperuricemia is another problem. Okay. So we discussed endotherapy, surgery we just mentioned, and this patient, the biliary part also will have to be tackled. Okay, if there's a biliary obstruction, significant, that will have to be tackled. Most probably when a surgery is, if a surgery is done, that will be tackled. Diabetes is there. Now, can you just mention the names of various tests which are used to diagnose exocrine dysfunction? Just tell the names. That's it. Okay. Oh.
Enzymes.
Okay, so you are doing secreting test. Okay, fine. What are the simpler tests? It is because of the difficulty of doing it, and practically it is not available in most of the hospitals. We have gone for indirect tests. So what are the indirect tests? Fecal elastase, okay, fecal elastase, then fecal chymotrypsin, fecal fat estimation, qualitative, semi-quantitative, quantitative. Various tests are there like a Sudan, no?
3 stain.
Sudan 3, then acid steatocrat test, it is quantitative, and finally Van de Kamer test, which is the 72-hour fat balance study, which is practically not done anywhere. Okay, so these are the 3 tests. Then very indirect. What is PABA test? Just know PABA test, pancreatitis test, and dual label shielding test. Okay, just know the name in case these are asked in the Viva. So PABA test, pancreatitis test, and yeah, just know the name of all those things, which some of the old examiners like us may ask.
Yeah.
This is to get
NBT
more
PABA.
points. Okay,
NBT.
Professor Rajesh, is there anything else to discuss?
Yeah, no, I think mostly all the management approach was quite.
Can you just summarize the overall case and its management in a nutshell, Professor Rajesh?
I think, can we, in this case patient, what was done? I think, do we have any other information also?
I think patient is still awaiting MRCP, no?
Oh, okay.
Suren?
No, sir. We went ahead with phrase procedure, sir.
So the patient undergone the procedure.
Yes, sir.
Oh, okay, how is he after that?
He's currently pain-free, sir. He's been started on pancreatic enzyme replacement therapy also.
Phrase procedure and cholecystectomy. Okay.
What I would suggest is keep a list of pain management in patients with chronic pancreatitis and have columns, have columns for pharmacotherapy, endotherapy, surgery. Have all these 3. And once you have that, the outcome of each of these, and an ESWL. So keep all the 4 in hand and just see what will be the response indications first. What are the contraindications? And then which one would you consider when? And what will be the outcome of pain relief in these patients? So just keep this table in front as you're sitting before you enter the examination hall. So once you have this as a ready reckoner, it's easy for you to answer. Okay, because ultimately patient has come for pain, patients come for recurrent pancreatitis, and you want to relieve him of the pain. Once you get that table right, you'll find that maybe, as Professor Rajesh was telling, that with so much of ductal stones and large stone and a patient suffering for so many years, surgery, I thought, would be the way forward in this particular patient.
Yeah, that's one
But
long-term results better also.
Yeah, once you have the table, it's easy for you to just do that homework. Yeah.
Can you?
And also,
The favorable outcome of endotherapy, what are the morphological characteristics from the, can you give some, like, which are usually do better, no? The outcome end better in which patients? Patient selection is very important when you do endotherapy. So which are the patients which are likely to do better?
Sir, if there are only calculi predominantly in the head and proximal body, and when there is absence of calcification of the head.
Single dominant stricture, or there's a single dominant stone. So that is more, you can remove it more easily. Outcomes usually better. When there is a stone behind the stricture or in the tail, so those are usually less. So that's why. So in this case, here also multiple calculi in the parenchyma also. It was not
Yes,
only ductal calculi. So probably surgery is a better option, I think.
is there a role for EUS in the pain management? And apart from its role in pseudocyst and pancreatic abscess, also which may cause this pain, is there any specific role of EUS in purely pain management?
Serous plexus block.
Block. Will you not do neurolysis?
No, sir.
Why? Okay. Okay.
What is the
Okay.
drawback of your block? What is the main issue actually? Because the side effects, hypertension, but
Immediate side hypotension.
It's short lasting. So, it's usually is less than up to 6 months max. So
that's why we don't want to do a lysis in a benign condition. I think it is 10:54. The platform will stop automatically at 10 o'clock, I think. So we have to wind up. So it was a good case. Professor Rajesh, can you just sum up and the tips to them regarding?
Yeah, I think.
for-
Yeah, I think when you have the history, one thing is to take the history more meticulously. Some of the, I think history was a bit vague, that abdominal pain could be anything. So the initial descriptions not. And when
Yes, sir.
you're very clear it's pancreatic pain, then you can it's a pancreatic pain. Otherwise, you can mention that it's look like an acute pancreatitis episode with previous history, so history of recurrent acute pancreatitis, or maybe it was abdominal pain of childhood. Such things you can give. And I think the history should have been some more details should have been there. I think I felt a bit lacking in some details. And as when there was a very important finding, physical finding, definitely history you should mention that when some things led into that. A lot of negative history was not given. I think some things was just very sketchy. I feel. And I think more DD should have been there in this case when the findings, the history was a bit vague, so it should as sir told, the impression we already know it's pancreatitis and everything, so that's the impression shouldn't come. So some amount of you should prepare for the surprises with the other DD also. You should discuss and see these are the points for, and this is more likely you rank like the order of preference. This is the most likely, less likely, unlikely, not being considered like the difference.
Yeah, thank you, Professor.
I think it was discussed okay. I think I mentioned most of the questions in my mind.
Saran, your presentation, you are very confident in the presentation. One important point which I noticed was you have had an uninterrupted, flawless presentation. So your presentation aspect, the intonation, everything is perfect. Only thing is that some more points should have been there. Okay. So
Okay,
I
sir.
think that part you will take care of it. And
Yes.
Naveen and Dheeraj, especially Naveen, don't be too abrupt with the answers. You have to be little more diplomatic. You know the stuff. And but the examination not will hurt. This is not an argument. This is just discussion. So you should not feel offended. Okay. After all, examination is an important day for you. So the examination never should not feel get offended. That's an important thing. So be gentle and polite when you answer, and don't try to argue. This is one thing. There are some candidates who are just lost due to arguing. So don't try to argue. We can politely tell this is, or if you have difference of opinion, you can say that this is how I have learned like that. But don't try to rattle off reference from this article, that article, and try so that you know more than the examiners. You all know the clear-cut details of the various diseases much more than us because we have not read Messenger for quite some time. And you are reading it on a day-to-day basis, or you have revised it many times. So, but in spite of that, don't try to show references, etc., and try to argue. This is I am telling because some candidates have lost examination simply due to the arguing. Okay, so otherwise, it was a good discussion, good case. Thank you, Professor Rajesh, for your wonderful cooperation, and thank you, Saran, for taking up the case and presenting it. And also, I thank you, Dheeraj and Naveen, for the active discussion. And also, last but not the least,